Good afternoon.
Okay. Thank you.
So I'm going to speak to you today about MR-guided breast biopsy. And I'm going to start with the first case of a 40-year-old lady who comes with a palpable lump in her right breast. This is her mammogram, which shows an asymmetric density in the upper outer aspect of the right breast, which corresponded to her palpable abnormality, and the rest of her mammogram was unremarkable. She had an ultrasound which confirmed the presence of a 2-centimetre irregular hypoechoic mass. This was biopsied and yielded invasive lobular cancer. So my first question is, what is your next step? Do you A, recommend a wide local excision and sentinel node biopsy? Do you B, recommend mastectomy? C, refer her to oncology for neoadjuvant chemotherapy? Or do you D, recommend a staging MRI? So can you please vote? Okay, can I see the answers, please? Yes, the answer is D, recommend a staging MRI. And this is her staging MRI. This is the cancer that she presented with in the upper outer quadrant of the breast. This was the second cancer in the upper inner quadrant of the breast. And this was the third cancer in the superior aspect of the left breast, the contralateral breast. And this is why we do MR, to pick up these mammographically occult lesions that will affect the overall patient treatment and management. And we know that MR has tremendous sensitivity, but has a relatively limited specificity with overlap between benign and malignant lesions. So this has led to the development of MR-guided biopsy, which has now become an essential component of breast imaging practice. So go on to my next case. This is a 30-year-old lady who was referred for high-risk screening MR. She had had a normal mammogram 3 months previously. And here you can see just at the very back of the breast this small 6-millimetre irregular enhancing mass. On the kinetic colour map, you can see here that it demonstrates wash-in and rapid wash-out kinetics. This was called a BI-RADS 4 lesion. And what is your next step? Do you A, recommend a repeat mammogram, B, recommend ultrasound, C, recommend MR-guided biopsy, or D, recommend a 6-month follow-up MR? Can you please vote? And can I see the answers, please? Actually, the answer is B. You recommend an ultrasound. It's called a second-look ultrasound. And so the lady went for a second-look ultrasound, and it confirmed an ultrasound correlate, 6-millimetre hypoechoic nodule, which was biopsied and came back as invasive ductal cancer. So, regarding MR-detected suspicious lesions in second-look ultrasound, sorry, it's a bit of a convoluted slide, what's the correct answer? A, second-look ultrasound is needed only in select cases. B, non-mass-like enhancement on MR is more likely to be identified at ultrasound than mass-like enhancement. C, the probability of malignancy is higher for MR-detected lesions that don't have an ultrasound correlate. D, follow-up is unnecessary if ultrasound biopsy of an MR correlate yields benign pathology. Or E, MR-guided biopsy is necessary if the lesion lacks an ultrasound correlate. Can you please vote? Can I have the answers, please? Yes, E, MR-guided biopsy is necessary if the lesion lacks an ultrasound correlate. So with second-look ultrasound, well, first of all, you need histological confirmation if you have a suspicious lesion on MR. And the first thing we do is second-look ultrasound. And this is a targeted breast exam where we specifically look for the MR correlate. And the advantage of doing a biopsy under ultrasound over MR is obviously its accessibility. It's less costly and faster to do. And you can, it's performed with real-time visualization. You can see your needle going through the lesion, and there's less patient discomfort. And targeted ultrasound has been reported to identify an ultrasound correlate in between 23 to 89% of lesions detected at MR. The probability of malignancy is higher for MR-detected lesions that have an ultrasound correlate, and larger lesions, masses, and invasive ductal cancers are more likely to be identified at ultrasound than smaller lesions, non-mass-like enhancement, and invasive lobular cancers. When performing your second-look ultrasound, it's important to remember the differences in position of the patient between the MR and ultrasound. With MR, the patient is imaged in the prone position, And with ultrasound, the patient is imaged in the oblique, supine oblique position. So lesions can vary slightly in their location. You must review your MR images prior to the second ultrasound so that you have an idea of where the lesion is going to be. And look for any adjacent landmarks, cysts or scarring that may help guide you to where the lesion is. The findings at second ultrasound of MR correlates are reported to be very subtle, with about 3% of cancers lacking the classic features of malignancy. So we generally have a lower threshold for biopsying lesions if it looks like it might be an MR correlate. And you perform your biopsy, and then you place a clip and perform a post-clip mammogram. So this is a case of a 50-year-old female who presented to our clinic with metastatic, biopsy-proven metastatic left breast adenocarcinoma to her lymph node. Her mammogram was normal, but on her MR you can see this area of non-mass-like a clumped enhancement within the central breast. She came for a second look ultrasound, and amongst all these fatty lobules, you can see this vague area of altered echogenicity, which seemed to be the only correlate on ultrasound to the MR findings. So we biopsy this and put a clip in. And here you can see in the post-clip mammogram, the clip lies within this relatively bland-looking glandular tissue within the breast. But the biopsy came back as invasive lobular cancers. So definitely your threshold should be lower when you're looking at these cases. So when we get a malignant pathology from a second ultrasound biopsy, that's easy, we treat. But what happens if we get benign pathology? Well, careful radiology-pathology correlation and review of the ultrasound and MR images is necessary. Many women have lots of benign lesions within the breast at ultrasound. So it could be the case where the suspicious MR lesion is not the lesion that is actually biopsied at ultrasound. And in one study, they found that the original lesion detected MR was not the lesion biopsied in about 12% of cases. So true correlation can only be confirmed if a follow-up MR is performed, and you can see that the clip that you placed at biopsy corresponds to the lesion that was originally seen on the MR. If it doesn't, then the patient needs to go on to an MR-guided biopsy. This is just an example that we had, a lady who came for a staging breast cancer. She had an occult breast cancer in the superior aspect of her breast. Her staging MR showed a second area of abnormal enhancement within the inferior left breast. She came for a second look ultrasound, and it showed a small hypoechoic nodule in the inferior breast, but this was the only thing we could see, so we biopsied it and put a clip in. The pathology came back as PASH and a sclerosing lesion. We weren't happy that this was a discordant finding, more because of the size of the ultrasound lesion did not match the MR lesion. So we brought her back for a follow-up MR 2 weeks after the biopsy. And here you can see artifact from the clip at the very posterior aspect of the enhancement. So we felt this was, we had missed the actual lesion, and we went on to perform an MR biopsy of the anterior enhancement, and this came back as an invasive ductal cancer. So what about lesions that we don't see an ultrasound correlate of? Well, the probability of malignancy for sonographically occult lesions with suspicious features in MR, BI-RADS 4 or 5 lesions is high, but between 20 to 25% in the literature. And this is higher than the highest probability of malignancy accepted for BI-RADS 3 lesions. So MR-guided biopsy must be performed for lesions that lack an ultrasound correlate. And another question. Regarding lesions detected on MRI of the breast, what's the correct answer? MR biopsy is recommended for BI-RADS 3, 4 and 5 lesions. The positive predictive value of malignancy is higher for screening MRI than diagnostic MR. Cancers manifest more frequently as non-mass-like enhancement on MR than masses. Biopsy is rarely necessary for lesions less than 5 millimeters detected on MR. And regarding kinetic enhancement, MR-detected lesions that demonstrate persistent enhancement are most associated with cancer. And can you please vote? Can I have the answers, please? So actually, the answer is D. Biopsy is rarely necessary for lesions less than 5 millimeters. So what should we biopsy? Well, there's a couple of things we have to take into account. We need to take into account the clinical indication for doing the MR, the size of the lesion, morphology, kinetics, and the BI-RADS classification. In a large study of 2,600 breast MRs, the authors found that the positive predictive value overall of malignancy was 28%. But when you stratify this into clinical indication, it's higher in the diagnostic setting than the screening setting. What about lesion characteristics? Well, cancers manifested more frequently as masses than non-masses or foci. Masses with irregular shapes and irregular or spiculated margins have a higher likelihood of malignancy. When it comes to non-mass-like enhancement, linear, ductal and segmental distribution and clumped internal enhancement are more likely to represent cancer. And rapid initial enhancement and plateau and washout delayed enhancement is most associated with cancer. With regard to size, the larger the lesion, the more likely it is to be malignant. And in one study by Lieberman et al., they found that in their lesions less than 5 millimetres, they had 666 breast MRs, and of the lesions that were less than 5 millimetres, only 3% of those were cancer. So biopsy is rarely necessary for lesions less than 5 millimetres because of the low likelihood of cancer. But obviously, if a lesion is less than 5 millimetres and it has another very suspicious BI-RADS lexicon descriptor, then they should proceed for further evaluation. With regard to PPV of malignancy based on BI-RADS classification, studies have found BI-RADS 4, the PPV of malignancy is about 21%, and for BI-RADS 5 lesions about 71%, which is high, but it's less than the BI-RADS, the PPV of malignancy BI-RADS 5 mammographic lesions, which is 95%. But the risk of malignancy for BI-RADS 3 lesions is less than 2%. So BI-RADS 4 and 5 lesions are high-risk lesions and warrant biopsy. So here's another question. Regarding MR biopsy, what is the correct answer? Is it A, there are no contraindications to biopsy? B, non-contrast study is performed to localize the lesion? C, biopsy is performed under real-time guidance? And D, biopsy should be performed with the breast in compression. Okay, please vote. Can I have the answers, please? And yes, that's right. The biopsy is performed with the breast in compression, unlike the diagnostic breast MR. And the reason we need compression is that we need to keep the breast stable, prevent patient motion, and also we need the breast has to be compressed to allow the needle to to traverse through the breast. So before a breast MR, it's crucial that you sit down with before a breast MR biopsy, it's crucial that you sit down with the patient and explain the procedure in detail to the patient so that they have a clear understanding of what's going to happen. And you discuss the impact of patient motion with the patient, discuss the possibility that you may not see the lesion at the time of biopsy, and discuss locations that may be difficult to safely access at the time of biopsy. And this leads for a less anxious and calmer patient. And at this stage, consent is taken and an IV cannula is placed. This is a lady who came to our clinic for an MR-guided biopsy of this segmental non-mass-like enhancement in the superior breast. But at the time of the MR biopsy, you can see the enhancement is gone. So with regard to non-visualization of lesions at the time of biopsy, do we A, recommend a routine MR follow-up in 1 year? Do we B, perform random biopsies in the area of previous enhancement? Do we C, recommend no follow-up? Do we D, reschedule the biopsy for week 2 of the next menstrual cycle if she's premenopausal? Or do we E, recommend a short-term follow-up MR? Oh, sorry. Well, that was the answer, that we recommend a short-term follow-up MR. And the first thing we need to do when we don't see a lesion at the time of biopsy, we have to make sure there's no technical problem. So make sure that the contrast hasn't tissued into the hand. And if there's no technical problem, then we usually release compression because compression can affect the inflow of contrast into the breast, and we perform delayed imaging. And even if you still can't see the abnormality at that stage, then obviously the biopsy has to be cancelled. And this is not an infrequent occurrence. In the literature, up to 13% of MR-guided biopsies are cancelled. The working hypothesis is that it's due to cyclical hormonal changes which affect the parenchymal enhancement. But in one recent study by Brennan et al., they found that of their patients who had their MR-guided biopsies cancelled, about 40% of them were postmenopausal, so leading them to believe that there were some other factors at play, either some inflammatory changes, or possibly overcompression of the breast. But in those patients that had their breast MR-guided biopsies cancelled, there is a subsequent cancer detection rate of between 0 and 10%. And the cancers detected are both invasive and ductal carcinoma in situ. So there is a low but a significant risk of a cancer in the same breast. And the recommendations are to do a 6-month follow-up MR to see if the enhancement represents and if there's any enlargement in that area. Again, preparation is the key to a successful breast MR biopsy. the person doing the biopsy needs to review the diagnostic images so you have a clear idea of where the lesion is in the breast and you can determine your approach. We use the grid localizing system, and you can come in either medially or laterally using this approach. Pay attention to landmarks in the diagnostic MR images so you know where to find the lesion, because the compressed breast can look slightly different to the uncompressed breast. And have the same team performing the biopsy if possible at all times, because they are familiar with the procedure and they're familiar with the nuances of the procedure. Speed and efficiency is of paramount importance when performing a breast MR. You have a limited window of contrast enhancement. Malignant lesions wash out rapidly, and the background breast enhancement increases over time. So that gives you about 20 to 30-minute window of which you can see the lesion. The more prolonged the procedure, the more difficult it is to visualize your lesion, and the more likely it is that the patient will move. So you prepare your biopsy tray beforehand. And there are multiple different MR breast biopsy kits, but the basic components are the same. And they consist of a needle guide block, which sits in the grid, a coaxial system, which is comprised of an introducer and guide sheet, an obturator, and then you have a biopsy needle and your biopsy driver. And I said there are several guidance techniques, but we use the grid localizing technique. And this is just your basic, your MR kit. Here you have your needle guide block, which sits in one of the squares of the grid, and within the guide block there are a number of holes through which your needle is inserted. This is your coaxial system, where you have your introducer, you have your external sheath with depth gradations and a depth stop, and this is your obturator, and the obturator can be imaged within the breast. This is the needle with a 2 centimetre biopsy chamber, and there's about a 5 millimetre dead space proximal to this. The needle is attached to a basket which collects the specimens, and this is a vacuum-assisted device which is controlled by a foot pump. So, like good preparation, positioning is also key to a successful biopsy. You have only one chance at positioning. The biopsy is performed with the patient prone on the breast coil and the breast is compressed between the median and lateral plates. It's important that a trained MR or mammographic technician position the patient and ensure that the breast sits deeply within the coil. And the radiologist who's performing the procedure should be in the room to assist with the positioning so that they are sure that the expected location of the breast is within the field of the grid. You ensure patient comfort by having padding at pressure points, and then you put the breast in controlled compression, where the breast is compressed between the grid and the plate. There needs to be enough compression, again, to prevent any motion and to allow the needle to traverse the breast, but too much compression will affect the inflow of contrast into the breast. And then a fiducial is placed within the grid to assist triangulation of the lesion. And here is our breast biopsy coil set up for a medial breast approach. You can see a plate here, and the contralateral breast sits on the plate, keeping it out of the way. Here's the breast in position, pulled deeply into the breast coil. We have the grid here, and the fiducial is sitting within one of the squares in the grid, and this helps with triangulation of the lesion. So then we perform our localizing images. We perform sagittal T1 FATSAT pre and post contrast images. And once we see our lesion, we can then localize our lesion manually, or we can localize it using localization software. The localization software is really easy. You identify your lesion and your fiducial on your MR images, and then the software specifies the particular square in the grid to put your needle guide block into, and the hole within the needle guide block to place your needle. And it also gives you depth information. So for this case, we can see our software is telling us that the square we need to use is C6, and the hole that we need to insert our needle into is in the upper left-hand corner. The depth that we need to place our introducer is to 4.3 centimetres, and at that depth, the tip of the obturator sits in the middle of your sampling area. So if we go back to our image of the breast and the coil, our fiducial is C4, and you can see the square that we need to access is C6, which is here. You can also localize the lesion manually. For this, you need planning worksheets. This is an example of a planning worksheet. And depending on the approach, you have different worksheets. So you have the same worksheet for a lateral left approach and a medial right approach, and you have the same worksheet for a medial left and a lateral right approach. And here you have an image view, a sagittal image view, and you have a patient image view. And then you go back to your localizing images and you find your fiducial, and then you scroll through your sagittal images and you find your lesion, and you place an X or mark where the lesion is. And then you go back to the skin and you can see where the grid and the skin and the grid, and you can see that on the images by the indentations of the grid on the skin here. And here we can see our fiducial, and we can see that our lesion lies 2 squares superior to our fiducial, and the hole that we need to place our needle in is in the superior aspect is in the middle of that square closest to the head. So we go back to our planning worksheet. Our fiducial is in square 4. Our lesion is 2 squares superior to that in square 2. The hole that we need to place our needle within the needle block is in the middle of that square closest to the head. We then go back to the patient. Our fiducial is in square 4. Our lesion is in square 2. And the needle hole that we need to use is in the middle closest to the head. And then that gives us our XY coordinates. We then need to work out our Z-axis or our depth. And the depth is calculated by adding the number of sagittal slices from the skin to the lesion and multiplying it by the slice thickness. We also have to add the thickness of the needle guide, which is 2 centimetres. And once we have our coordinates, we can then proceed with our biopsy. And just like stereotactic biopsy, we clean the skin, anaesthetize the skin with lidocaine, and we also give lidocaine and adrenaline deeper into the breast tissue to prevent or reduce bleeding. We clean and anaesthetize the skin, and then we make a skin incision. We pass then we pass our introducer and our external sheath in through the needle guide into the breast. The depth stop on the exterior sheath is placed to the appropriate depth, and then you can lock the depth stop in place, and this prevents the needle moving in and out of the breast during the biopsy. We remove the introducer, and then we place our obturator, and then the tip of the obturator sits in the middle of the sampling site. Once then we can bring our patient back in and we perform further localizing images, and here you can see the tip of our obturator in the middle of the middle of the lesion. We then remove the obturator and we insert our biopsy needle, and we take our samples. You can take your samples in a clockwise around the clock, or else you can perform what's called directional sampling, where you aim where you think most of the lesion is. And the number of samples that you take depends on the needle gauge. Again, the bigger the needle, the smaller amount of samples you need to take. Once you've taken your samples, it's important to vacuum, aspirate and lavage the biopsy cavity. And the number of reasons for this: one, the hyper-intense T1 hematoma can really obscure visualization of the lesion and make it difficult to see if you've accurately sampled the lesion. It reduces patient discomfort, and it also minimises clip displacement. Once you're happy that you've sampled the lesion accurately, the lesion looks smaller and the post-biopsy changes are in the area where the lesion was, you deploy your marker clip. And you can perform post-clip images if you like, but it can be very difficult to see the artefact from the clip because of all the biopsy site changes, so it's not necessary. This is a case where we did perform it, and you can see artefact from the clip right in the middle of our lesion, but they're not normally as easy to see as this. And then you release the breast and apply digital pressure. And the patient then is transferred to the mammo suite, where you perform a post-biopsy mammogram. The mammogram is performed to see if the clip lies in the location expected from the MR images, and to see if the clip lies within the adjacent to biopsy site changes. Sometimes the clip doesn't lie adjacent to biopsy site changes, and then you know that the clip has migrated through during the biopsy. And this is quite a common occurrence due to the concertina effect when you release compression. And the complications are the same as any other breast biopsy. So the next question: the contraindications to MR-guided breast biopsy include A, thin breasts, B, dense breasts, C, posteromedial lesions, D, pregnancy, or E, lesions close to the chest wall. Can I have your answers, please? That's right, D, pregnancy. Pregnancy is contraindicated due to the potential teratogenic effects on the fetus, but actually lesion location is not a contraindication to breast MR. So what can we do for those awkward lesions that are difficult to access? Well, for posterior lesions, we can remove the padding from the material from the coil. We can position the patients with the arms down, and this allows the pectoralis muscle to relax and let the breast drop further down into the coil. We can try oblique positioning of the patient. Posteromedial lesions are the most difficult to access, and this is due to the anatomy of the coil, where the sternal bar is lower than the lateral bar. And in those cases, we need to just use a lateral approach. With thin breasts, you can minimize compression. You can insert a foam pad on the other side of the breast. You can use a blunt needle tip, which will decrease your dead space and reduce the risk of penetrating the contralateral skin. You can infiltrate the contralateral skin with lidocaine. This will give you a couple of extra millimeters of depth, and also anaesthise the skin if you do penetrate it. And you can use a half sample setting. Instead of a 2 centimetre biopsy sample chamber, you can use a 1 centimetre. For retroareolar lesions, similarly, it can be difficult to get good compression on these, for these lesions, and also putting padding behind them can help reduce needle displacement. Dense breasts, you can have this phenomenon called snow ploughing, where the needle, as it's been inserted into the breast, can push the tissue anteriorly. So to reduce this, you push and twist your introducer and overshoot your target by 1 centimetre and then pull back. So for lesions that are biopsied under MR guidance, what is the correct answer? A, most lesions biopsied under MR guidance are malignant. B, follow-up imaging is not necessary after a benign concordant MR-guided biopsy. Or C, follow-up MR is routinely performed 6 months after a benign concordant biopsy. Or D, stability of a lesion on post-biopsy MR requires a repeat biopsy. Can I have your answers, please?
C.
That's right. Follow-up MR is routinely performed 6 months after a benign concordant biopsy. Most of lesions biopsied under MR will be benign, about 50 to 70% of lesions. But of 8 to 12% of lesions that are biopsied that come back as benign have been inadequately biopsied. And of those, 14 to 18% will be malignant. So that gives us a 2.5 false negative rate of MR biopsy. And technical factors during the biopsy may contribute to suboptimal sampling: patient motion, coaxial displacement, or hematoma, which can make assessment of lesion sampling difficult during biopsy. So follow-up MR is necessary for true correlation. If the lesion is less conspicuous or absent, you've adequately sampled it. If the lesion is enlarging, then obviously you need to repeat the biopsy or excise the lesion. Lack of change, there's still some not really sure about what to do with these lesions. An analysis of location of the clip is unreliable because you can have clip migration. No real consensus when to do MR. Most groups do it at about 6 months, and this is based on data that show that missed cancers showed no appreciable change in size less than 6 months. This is one of our discordant cases where after biopsy, you can see the biopsy site changes here adjacent to a spiculated mass. We thought this was a discordant biopsy, so we brought her back 2 weeks after the biopsy. You can see there's been no change in the lesion, and the clip actually lay about a centimetre posterior to the lesion. So she went on to have this excised, and it came back as a small focus of DCIS. So what about high-risk lesions at MR biopsy? Do we A, recommend surgical excision, B, recommend follow-up MR in 6 months, C, recommend surgical excision if the biopsy needle is smaller than 11 gauge, or D, recommend surgical excision if biopsy was not vacuum assisted? And can I have your answers, please? Yes, surgical excision is recommended for all high-risk lesions detected by MR-guided breast biopsy. So how concerned are we that we may be missing a cancer when we encounter a high-risk lesion at MR biopsy? Well, there's a large review analysis. There's about 18 articles detailing the frequency and upgrade rate of high-risk lesions. And you can see the percentage of high-risk lesions detected. It varies from between 3 and 21%, and the percentage upgrade varies between 13 and 57%. Atypical ductal hyperplasia is the most common high-risk lesion and has the highest upgrade rate, with about 2/3 going to DCIS and 1/3 to invasive carcinoma. And there are no specific morphologic or kinetic characteristics on MR that can predict atypia, and there is no imaging features that can predict subsequent upgrade. They found a significantly higher upgrade rate in women with a personal history of breast cancer, and the recommendation is still surgical management of all high-risk lesions, but larger prospective studies are needed. And just a couple of slides then about MR-guided treatment. With the evolution of all these imaging techniques, we're detecting smaller cancers, and the standard of care for these lesions is breast conservation. But we're now moving towards treatment with more, minimally invasive techniques. But to compete with breast conservation, there has to be 100% tumour necrosis. The advantages of these techniques are a better cosmetic result, it's more comfortable for the patient, hospital stay is reduced, and the costs are less. These techniques use ultrasound for guidance, but there's a problem distinguishing ablating tumour from residual tumour post-treatment with ultrasound. Everything just looks shadowy. MR is the best imaging method for tumour targeting, ablation and treatment monitoring, and evaluation of tumour response to treatment. And the lack of contrast enhancement within the tumour on T1 images confirms successful ablation. There are a number of different techniques. MR-guided radiofrequency ablation, an electrode is placed into the target under ultrasound guidance, and a current is applied, which destroys the cells by thermocoagulation. Cryoablation is another promising technique where a cryoprobe is inserted into the breast under ultrasound guidance. The patient has this done on the MR table, and the cryoprobe destroys cells by cooling them to minus 160 degrees. The least invasive technique of them all is MR-guided high-intensity frequency ultrasound, which generates ultrasound beams and delivers heat to the target and causes tumour necrosis. And there actually are dedicated breast high-intensity focused ultrasound platforms now integrated into some MR scanners. There is only a small number of preliminary studies looking at this, with varying tumour rates of tumour necrosis of between 20 to 100%. The low tumour necrosis rates are thought to be due to MRs not being as good at detecting intraductal components. So currently indications for this kind of treatment are tumours less than 2 centimetres, a localised tumour, and no DCIS. But further clinical trials and long-term follow-up is necessary. So in conclusion, MR biopsy is now a standard breast imaging procedure. Preparation, positioning and trained team are key. It's so important to make sure you've got radiology-pathology correlation and to perform a follow-up MR in benign concordant biopsies. And high-risk lesions at present still require surgical excision. And if you are performing MR-guided biopsy, it's important to audit your practice. Thank you. Thank you.